I need to tell you something I've been carrying for a long time, something that may cost me a few friendships in surgical suites, but I don't care anymore, because what I'm about to say could save your mother's life, or your father's, or someone you love so much that the thought of losing them makes it hard to breathe. I've spent 32 years in medicine. I started as a surgeon, then moved into geriatrics, the medicine of aging. And it was in that transition that I saw something most surgeons never see. What happens after the operation is declared a success. What happens 6 months later? What happens to the person who walked into that hospital on their own, 2 feet, and never quite walked back out? I'm not here to attack surgeons. The ones I trained with are brilliant, dedicated people. I'm here to talk about a system that was not built for bodies over 65, about consent forms that list the risks in fine print, while the real risks, the ones we discuss among ourselves in the break room, never make it onto the page. About 5 specific surgeries that are performed hundreds of thousands of times every year, that are called successful by every metric we use to measure success, and that quietly destroy the lives of older patients at a rate that should make every one of us furious. I know this because I watched it happen to my patients. And I watched it almost happen to my own mother. Her name is Eleanor. She's 81 now. 3 years ago, a spine surgeon sat across from her at his desk, pointed to her MRI, and told her she needed a lumbar fusion. He said it calmly, the way you'd recommend a hotel. He said the surgery had a 90% success rate. He said she'd be back on her feet in 6 weeks. What he did not say, what the consent form did not say, is what I'm going to tell you right now. Let me start with a woman named Dorota. She was 74 when I first met her. Sharp, funny, completely independent. She drove herself to her book club every Tuesday and made pierogies from scratch every Sunday for her grandchildren. Her orthopedic surgeon told her she needed a total hip replacement, routine procedure, one of the most commonly performed surgeries in the world. She went in on a Thursday. The surgery was textbook, and then the cascade began. What nobody explained to Dorota, what the consent form reduced to a statistical footnote, is that general anesthesia in patients over 70 has a well-documented relationship with something called post-operative cognitive dysfunction, POCD. Studies published in the journal Anesthesiology show that up to 40% of elderly patients experience measurable cognitive decline after major surgery under general anesthesia. 40%. That is not a side effect. That is nearly every other patient. For Dorota, the confusion that appeared after surgery was first called normal disorientation. Then it was called hospital delirium. Then, 8 months later, it was called early-stage dementia. The surgery worked. Dorota didn't. Her hip moved perfectly. Her mind had been altered in ways that no rehabilitation could reverse. She stopped driving. She stopped hosting Sundays. The last time I saw her, she didn't remember the name of her book club, and her surgeon's notes still read, "Successful outcome, no complications." Now let me tell you about a man named Bernard, 77, retired schoolteacher. He had been living with knee pain for 2 years when his orthopedic surgeon recommended a total knee replacement. Bernard was active, walked his dog every morning, tended a garden that was genuinely something to see in July. His surgeon told him the procedure had excellent long-term outcomes. What the surgeon did not mention is that research published in the New England Journal of Medicine found that for patients with moderate osteoarthritis, which is what Bernard had, total knee replacement produced no better functional outcomes than a structured physical therapy program. None. The same result. And physical therapy carries no 30-day mortality risk. Total knee replacement in patients over 75 carries a mortality rate of approximately 1 to 2% within the first year, and a 15% chance of placement in a long-term care facility within 12 months of the procedure. Bernard ended up in that 15%. He never went back to that garden. Why does this happen? The science is clear, and it should make you angry. The aging body is not simply a slower version of a younger body. It is physiologically different in ways that matter enormously when you are cutting into it and asking it to recover. After 65, skeletal muscle mass declines by roughly 1 to 2% every year, a process called sarcopenia. When an older patient is immobilized for surgery and recovery, that muscle loss accelerates dramatically. Research from the Journal of the American Geriatric Society shows that just 10 days of bed rest in a patient over 70 can cause muscle loss equivalent to a decade of normal aging. 10 days. That loss often never fully returns, and without muscle, the body cannot support the very joint that was just replaced. Then there is the hospital environment itself. Older brains are exquisitely sensitive to disruption. Unfamiliar sounds, disrupted sleep, catheters, IV lines, the relentless fluorescent light of a hospital ward. This environment triggers what clinicians call ICU-acquired delirium even outside the ICU, and in older patients, that delirium is not always temporary. It can be the event that tips a brain from compensated aging into accelerated decline. A landmark study in The Lancet found that a single episode of hospital delirium in patients over 70 was associated with a twofold increase in the rate of subsequent cognitive decline. Not a risk factor, a trigger. And there is the anesthesia itself, the drugs we use to put patients under, particularly the older volatile anesthetic agents, have neurotoxic effects on aging neural tissue that we did not fully understand until the last decade. Research from Duke University's Center for Perioperative Organ Protection has shown that these agents cause neuroinflammation in older brains that can persist for months. Months of inflammatory damage, happening silently, while everyone is celebrating that the surgery went well. These are not fringe findings. These are published in the most respected journals in medicine. They are simply not in the room when your mother signs the consent form. So let me name the 5 surgeries. I'm not telling you these procedures are wrong. I am telling you that for patients over 70, the full picture looks very different from the brochure, and that your surgeon may not have handed you the full picture. The first is total knee replacement. Technical success rate above 95%. But for patients over 75 with moderate rather than severe arthritis, functional outcomes mirror those of intensive physical therapy in randomized controlled trials. Before surgery, ask specifically about an extended trial of structured physical therapy combined with corticosteroid or hyaluronic acid injections. Ask your surgeon for the data comparing surgery to conservative management for your specific severity level. The second is spinal fusion for degenerative disc disease. This is the surgery that was recommended to my mother. Fusion rates are high. Pain relief rates are inconsistent. Studies published in Spine show that up to 40% of patients report no significant improvement in pain scores 1 year after surgery. And fusion at one level creates mechanical stress at adjacent levels, frequently leading to what is called adjacent segment disease, and a second surgery within 5 years. For older patients, that second surgery carries compounded risk. Ask about spinal cord stimulation, targeted physical therapy, and pain management protocols before agreeing to fusion. The third is carotid endarterectomy, the surgical removal of plaque from the carotid artery to prevent stroke. For patients with symptomatic stenosis above 70%, the evidence supports surgery. But for asymptomatic stenosis, a 2020 meta-analysis in JAMA Neurology found that modern medical management with statins and antiplatelet therapy produced outcomes statistically equivalent to surgery in many patient populations. The surgery itself carries a 1 to 3% risk of stroke or death in the perioperative period, the very outcome it is meant to prevent. Ask whether your stenosis is symptomatic. Ask whether you have been optimized on medical therapy first. The fourth is open abdominal surgery for hernia repair in frail older patients. Laparoscopic repair is far less invasive, with dramatically better recovery profiles in elderly patients, yet some surgeons still default to open repair based on training preference or anatomical complexity. Frailty is a measurable clinical state. Ask whether a frailty assessment has been performed. Ask specifically whether a minimally invasive approach is possible. A 2019 study in the British Journal of Surgery found that frailty status was a stronger predictor of surgical outcome than age alone, and that frail patients undergoing elective open surgery had complication rates 3 times higher than non-frail patients of the same age. The fifth is pacemaker implantation and cardiac device surgery in patients with advanced dementia. This is the hardest one to talk about because it feels like withholding care. But research from the Journal of the American College of Cardiology shows that in patients with advanced cognitive impairment, implantable cardiac devices do not improve quality of life and are associated with increased hospitalization and procedure-related complications without meaningful extension of comfortable living. Goals of care conversations, what your loved one actually wanted, what their life looks like, what comfort means to them, should happen before the referral to the electrophysiologist, not after the device has already been scheduled. So what do? You go into that appointment prepared. Before any elective surgery for a parent or loved one over 70, I want you to ask 5 questions. 1. What is the surgical outcome rate, and what does outcome mean? Pain reduction, function, or simply technical completion of the procedure? 2. What are the alternatives, and has my parent been given a documented trial of the most effective non-surgical option? 3. Has a frailty assessment been performed? Ask for the clinical frailty scale score. 4. What is the 30-day and 1-year mortality rate for this surgery in patients of this age and frailty level, specifically, not the general population? And 5. What does recovery actually look like? Not best case, but median case. And what is the probability of discharge to a rehabilitation facility rather than directly home? These are not hostile questions. They are the questions that good surgeons welcome, because good surgeons want informed patients. If a surgeon becomes defensive when asked for outcome data, that is information too. My mother never had that spinal fusion. We asked for a trial of targeted physical therapy combined with a pain management protocol. 6 weeks later, her pain had decreased by more than half. She is 81, and last Sunday she sat at the head of the table for dinner. She complained that I'd brought the wrong kind of wine, and it was the most beautiful thing I'd heard in years. The surgery was unnecessary, not because the surgeon was wrong about what he saw on the MRI, but because nobody had asked what would happen if we didn't operate. Nobody had offered the alternative. Nobody had walked through what general anesthesia does to an 80-year-old brain that has been healthy for 8 decades and deserves the chance to stay that way. I'm not asking you to distrust medicine. I'm asking you to walk into that office the way you would walk into any other high-stakes decision, with questions, with alternatives in hand, and with the absolute certainty that you deserve the full picture, not the consent form. The full picture. Your loved ones built their lives with extraordinary care. They deserve the same care in return. Share this with someone who needs it before they sign.